welcome to SHINE, because, in healthcare, we love a good acronym. So SHINE is School Health Information and Nurse Education. My name's Kate Lufkin. I'm the Chief Communications Officer here at Montana Peds, and also the lead for the SHINE program. And I was saying as everybody was joining, fun fact, this is actually the largest registration group we've ever had for one of our sessions. So thank you all for making the time to be here and join us virtually today. I think this is such a cool platform where we can all be together in the same virtual room, from all across the state of Montana. So whether you're a nurse, administrator, teacher, or anybody else supporting student health, super grateful to have you here. Just a couple of quick housekeeping things, which I know is like the most painful phrase ever to get started, but just a couple of details for making the most out of each session. There are a lot of new people that we have registered today. So if you don't mind, would you put your name, your role, and then the organization you work with in the chat? That just helps us kind of identify who else here and then be able to tailor our follow-ups probably most appropriately too. And then secondly, I got a lot of educators on here too. And so we would love to see your faces. If you feel comfortable with that, we'd love to have you turn your video on. I know as a presenter myself in the past, I appreciate just seeing the visual feedback of people's faces to know, like, is this landing? Is this not landing? Or is everybody super confused? Are they incredibly bored? Et cetera, et cetera. So I imagine Crystal and Heidi will feel the same way. And then just a quick structure of the day. We'll start with a 20 to 30 minute presentation, followed with our subjects excerpts, followed by a Q&A and discussion opportunity. If you would please either add your questions in the chat or just hold on to them until the end so that we can get through the presentation and then be able to make the most of this discussion time together, that would be great. And then after this session, there will be a link that I will put in the chat. It'll be in the follow-up email as well next week. But we genuinely value your feedback, and it plays a huge role in helping us shape this program to best meet the needs of you and your school. And then finally, because we get this question all the time, the presentation is currently being recorded. Typically, I stop the recording as the discussion portion starts. Today, I'm going to keep it going just so that we can make sure on sort of the administrative side of this, we do our follow-up as best as possible. I will completely cut that out and delete it for the recording that then we post on YouTube and we share it with everybody. So really encourage you all to speak freely and openly during the Q&A session. Just please, we ask that you refrain from using any student names or particular identifiers, to just maintain the safety and respect of those individual students and families. But this is a really great opportunity to ask specific questions of our presenters and then also work together if you might have a specific kiddo or challenge or anything like that. Let's see. So just super quickly, because there are new people here, I just want to take a quick second to introduce Montana Peds. It seems a little bit strange to have a pediatrics company or organization putting on a school health program. But we are dedicated to increasing access to quality in healthcare, ensuring health equity for all of Montana's children. And we achieve this really through partnerships. And our partnerships are really who is in front of kiddos the most. We like to meet people where they're at. And in the cases of when we're talking about school health, right, extending these programs out to schools really makes the most sense. We work with hospitals, clinics, tribal health programs, nonprofit organizations all across the state. Everything we do is video-based care. We don't have a physical location. And all of our providers are spread across the state, across 6 different programs and topics that we have. Their normal PCPs and practice in hospitals and clinics, so their own practices every day. And then also work with Montana Peds. So we're committed to continuity, communication, and collaboration way more than we are competition, and really trying to reframe what rural health looks like. And what better place to do that than our great rural state of Montana for sure. So just lastly, super quick, what is SHINE? Because a lot of you guys, again, are super new here. So SHINE started really back in 2022 through a grant that was focused on supporting Montana's children with type 1 diabetes. As part of that program, we surveyed families and uncovered a broader need for training within the schools to better support students. And then last year, which was our first full year of that program, we quickly learned that schools and families were really looking for guidance on a variety of other health needs to support a bigger, broader variety of students. As we know, less than half of Montana's counties have access to a school nurse, and only a small handful of districts have full-time school nurses. So we really wanted to extend this program from being type 1 diabetes and school nurse focused last year to really anybody who is responsible for student health. So teachers, administrators, other staff. I don't need to tell you guys that because you're living and breathing it every single day. So our goal is to kind of really fill that gap in student health. And then just lastly, I like nerded out over the registration list the other night. And so you've kind of got our 2024 participants and then our 2023 participants too. And we really are hitting communities across the entire state. If anybody knows anyone down in that little, southeastern corner of the state that works in schools or clinics or school health or anything, let us know, because I don't like how empty that section of this map is. So just this program is still like all of Montana Peds programs, but this one for sure, is built by schools for schools. And so we have an advisory panel that really helps weigh in on what topics should we cover. We use those surveys at the end of each session to really influence that. And those are representatives of schools. So please fill out those surveys. If you're interested in being on that committee, let me know. But yeah, Shine is growing. We love it. I'm happy all of you guys are here. So without further ado, I'm excited to introduce Crystal Admonson along with Heidi Morris. Both Crystal and Heidi have successful mental and behavioral health practices of their own and bring a wealth of expertise in these areas. And I'm also incredibly honored to have them today, not just because it's such an important topic, but this is the first time 2 Montana pediatrics providers are presented.
It is muted, yeah.
In one of our programs. Hi, Chris.
Oh, sorry. I thought I was muted.
Oh, that's okay. No worries. Keep also excited that we have Montana Peds providers as presenters today. So Crystal works with our tribal program out at Fort Peck, providing absolutely incredible care, and Heidi's part of our pediatric mental and behavioral health team. So providing access to kiddos all across the state. So thank you guys for being here. I am going to turn it over to Crystal and Heidi.
Thank you, Kate. And thank you everyone for taking the time to connect. I was really, really, really excited for the invitation and really passionate about this topic. I started my career in Montana in a CSCT in a school-based program. The children I serve on Fort Peck are all in school-based health clinics. And a good portion of the kids on my caseload here in Billings, I am working really closely with their special ed teachers, their school counselors, their school nurses. So I really tried to do right by all of those kids and by all of those staff and what I put into the slides today. But also it's going to be like drinking from a fire hose. So I am going to do my best to get the information to you, and then I have to step out for a previous commitment. But Heidi, my partner in crime, does very, very similar work to and just really wanting to create space for those questions in the dialogue. So real quick, kind of what I'm hoping for you guys to take away from the presentation today is understanding differences between 3 common mental health disorders that we encounter very often in students, being able to recognize disruptive behaviors as mental health symptoms that students may be displaying. It's not as cut and dry as like a blood pressure or a blood sugar. And so just wanting to start to think about it through that lens. Absolutely wanting you to feel supported in resources that are available to school staff, regardless of training in mental health and regardless of role in the school. And then being able to develop language and action steps for when you see a student with disruptive symptoms, how can we describe that as a team, and what would next steps be in supporting and supporting their mental health, but also trying to decrease the disruption in those classroom settings. And I think this is such a great, Ross Greene is an author of Collaborative Problem Solving, if any of you are familiar with that resource. And when he talks, he shares that challenging kids are lacking the skills of flexibility, adaptability, frustration tolerance, problem solving. And the important thing I want to lift up from this is that's a cross diagnosis. And so I am going to be jumping into specific diagnoses today, but really want to lift up that where the rubber hits the road and where these kids struggle and staff struggle is because they're not adaptable, because they're easily frustrated or inflexible. And so we're just going to look at some of the clinical reasons for that and hopefully come away with some resources. So there's three kind of categories that I wanted to highlight today. I'm sure you're all familiar with several of them, and I wanted to take just a closer look. One of the most common mental health diagnoses that I hear referenced in the school setting is ADHD. And just recently, the diagnostic criteria for ADHD changed. And so when we're talking about ADHD, we're talking about attention deficit hyperactivity disorder. And there's actually 3 types or 3 kind of flavors that we see diagnostically. The first one is inattentive. So these are students who are distracted. They have a difficult time focusing. They struggle to kind of organize or kind of move through task completion. More kind of like an absent-minded professor feel to the inattentive type. Whereas the impulsive hyperactive type, the second flavor, that's where we see the kids who are just almost vibrating. Okay, they have really high energy. Their impulsivity is very high, so they're doing before they're thinking. And then we have the third type, which is a combination. And I would say in my own experience, this one shows up the most often in children because they meet criteria for all 3. But I think it's important to know that you can have a child who is not high energy, who does meet criteria for attention deficit. So that's the big thing I want to point out there. The next thing to know about ADHD is that because so many of the symptoms of ADHD are age appropriate for 3 and 4-year-olds, it's difficult to diagnose before about kindergarten. And so typically if we're seeing kids with these sorts of symptoms in a daycare or preschool setting, we're looking at other diagnoses. ADHD before the age of 5 is pretty rare. And something I want us to start thinking about in terms of behaviors and symptoms is what is the function or why, where is this behavior coming from? And so for kids with attention deficit disorder, it's due to a deficit in their ability to pay attention, to hold focus, and or to control their impulses. Okay? And so this is a neurodevelopmental disorder in kind of origin. And you'll see how that's different from some of the other disorders we're going to talk about next. Anxiety disorders is not a specific diagnosis, but is probably the next most common category that I see impact kids in the classroom and school settings. And there are several different types of anxiety disorders. The first one is separation anxiety disorder, and that is where a child experiences severe distress about being separated from a primary caregiver. Okay. And this is, again, pretty age appropriate in children as young as 2 or 3. But once we start to hit the school age, that it's developmentally not on target with what we would be expecting for them. The next one is social anxiety disorder. So that's less an anxiety about being away from their safe people and more an anxiety about being around a whole bunch of other people. And so you can see social anxiety disorder happen in a classroom setting. It can also happen in smaller settings if we're looking at like a smaller class size. Panic is a type of anxiety that specifically refers to kind of like the physical heart racing panic attacks is a specific specifier. And then generalized anxiety disorder is probably the closest to what we think about when we hear anxiety disorder. Generalized anxiety is, for those of you who've seen Inside Out 2, that is Miss Anxiety driving the control panel, right? She is just anxious about anything and everything. We have seen an increase in all anxiety disorders since kids have kind of returned to more typical school programming post-pandemic. Particularly separation anxiety disorder is happening more often post-pandemic than it was before. And if you remember with ADHD, it's uncommon or difficult to diagnose that before kindergarten, first grade. But anxiety disorders actually can pop up quite a bit younger. We can see anxiety disorders present in children, I would say typically around age 3, we can start to see anxiety really getting in the way of the work of childhood that these kids have in front of them. And then if you remember, ADHD is due to that attention deficit. So they're vibrating because they have so much energy or they can't focus their attention. Whereas these kiddos who have anxiety disorders, it's because of either one, they're trying to avoid unpleasant things, okay? And so if we have a kiddo with separation anxiety, we might see behavior spike when they're trying to avoid transitioning into school at the beginning of the day. And that meltdown or that tantrum in that instance isn't happening because they're impulsive. It's happening because they're trying to avoid leaving their caregiver, which is a source of anxiety, right? The other reason we see symptoms in kids with anxiety disorders is physiologically what cortisol and adrenaline dumps in our system. They're going to have increased heart rates. They're going to have kind of a fight or flight mechanism running, racing thoughts. And that's going to be kind of the foundation of the behaviors we see that can be disruptive. The final diagnosis, you are just like really on point with shifting things, Kate. Thanks. The final diagnosis is post-traumatic stress disorder, PTSD. And interestingly, this is in a different category than anxiety disorders. It has the word stress in it, but the like main characteristic, what separates it from anxiety disorders, is that it develops after an exposure to a traumatic event. And diagnostically, what we consider a traumatic event is if there's death, threatened death, serious injury, or sexual violence. And in adults, that happens to them, okay? So if an adult experiences a traumatic event, they are at risk of PTSD. However, a really important thing to be aware of with kids and teens is if the traumatic event happens to a primary caregiver or another significant adult in their life, that child can develop symptoms just from witnessing. And that's due to just the neurological wiring of attachment and the vulnerability of how much children rely on caregivers. They are neurologically wired to respond to threat that's happening to their caregiver as if it's happening to them. This is really important when you think about situations that a kid maybe was witness to, but sometimes we don't even know they were witness to until much later after the fact. Unlike anxiety disorders and ADHD, kiddos can present with PTSD at a very, very young age. I recently had a 2-year-old in my private practice who was demonstrating symptoms of PTSD. And so that can start much younger. The symptoms, rather than being due to avoidance or anxiety, are due to, it's almost like flashbacks. So intrusive re-experiencing. And so they have nightmares or they have thoughts about the icky or hard thing that don't go away. They might be trying to avoid things that remind them of the incident. Thought and mood alterations. It can be really scary when we talk about kids kind of dissociating or not being in touch with reality. And I would say more often than not always, but the majority of school-age kids I've had in my office who have an exposure to a traumatic event, that thought or mood alteration is actually a symptom of the PTSD and not a thought disorder or a cognitive impairment. And then the last thing that can cause symptoms is the physiological arousal again. So they're in that heightened flight or fight stage. So when we pull back and look at the big picture of all of these, the big old diagnostic manual that clinicians use, over here on the left in the red square, all of these symptoms could be indicative of ADHD or an anxiety disorder or PTSD. So irritability, distracted, poor focus, difficulty completing tasks. I want to pause. I think more often than not, people default to thinking that's ADHD, but all of those are also symptoms of PTSD. Okay. Reluctance to engage difficult tasks, forgetfulness, fidgety, hyperactive, restlessness, excessive talking, interrupting, difficulty waiting, tantrums, hypervigilance, decreased body awareness, the kids that just kind of don't know where they stop and the rest of the world starts. All of these could mean a child has ADHD. It could mean a child has an anxiety disorder. It could mean a child has PTSD. It could mean they have a couple of them. It could mean they have none of them. But the thing I really, really want to drill home is that if these behaviors are getting in the way of their ability to do school, to have friendships, to learn, I would consider that clinically significant. And ultimately, we don't have to know which one it is to be able to make a difference. And the first key takeaway from that is the point that suicidal thoughts, so a child talking about wanting to be dead or a child engaging in self-harming behaviors, that is not a symptom of PTSD or any of the other disorders. But all of the disorders I'm talking about today put a child at increased risk for suicidal thoughts or behaviors. And so that can definitely be something that we're screening for and just more aware of. Some things that separate out, if you can go back real quick, Kate. Some things that separate, maybe she can, maybe she can't. Just to clarify, all of those things are all of those diagnoses. The thing that separates anxiety disorders from ADHD, for example, is that you have the excessive worry. And so a child who has ADHD is not going to be particularly worried about things, okay? But a child who has an anxiety disorder, we are going to see that worry. And then the thing that makes PTSD different than an anxiety disorder or ADHD is that exposure to trauma. And so you can have ADHD or an anxiety disorder without any trauma history. But then PTSD, the other thing that's true for that particular diagnosis is the intrusive thoughts and memories. And so kids who are replaying violent scenes or just kind of getting, I call it sticky brain with my kids. They have these images playing in their head that they can't get rid of. That is more common in PTSD than it is in the other ones. Okay, now I'm ready. Off them. So what do we do? What do we do about it? And I have taught weekend-long workshops on this. And so I am going to do my best in 5 minutes to at least highlight these and know that you guys will have access to the slides and access to Heidi for the second half of the presentation to kind of drill this down even more. And my goal wasn't to give you interventions to use if you have a child with ADHD, and then different interventions to use with a child who has PTSD, because sometimes we don't know. There are kids on my caseload, and I am a licensed clinician, and sometimes it's hard for me to tell without some really sophisticated diagnostic resources that we just don't always have access to. And so all of the options listed through the rest of the slides are going to do good for any diagnosis. And so I just really want you guys to have these resources without thinking of it as an option. Have these resources as options for disruptive behaviors across diagnoses. And the first one is to get curious about the function of the behavior. Because as I mentioned before, the reason a symptom has developed or is happening, it comes from a protective place. Doesn't always come from a functional place, but that behavior exists to try to help the child adapt. And so kind of an example of getting curious would be that kid is always hiding under desks. I wonder why. Is it quieter or darker? Is it because if they're down there, they don't have to do their math? Is it because when they go down there, the teacher pays attention? So that's just kind of the thought process. And then some language that could sound like with student, hey, buddy, you're really good at hiding when things get hard. What other things are you good at when things get hard? Okay. And so we're not trying to shame the hiding behavior. We're just trying to get curious about what is hard for this kid. Is it too loud? Is the work? Is it attention? And see if there's a more adaptive way for him to get that need met. I'll also use this language when I'm talking to caregivers. If I'm making a call home, it might sound something like, hey, Auntie, we've noticed that Buddy's hiding from staff many times a day. Have you noticed anything that helps at home when he gets overwhelmed? Okay, so notice there, I'm not saying he struggles at school. Does he struggle at home? Because all due respect, a lot of times the answer I get is, no, we never see that behavior at home. And so the language I like to use here is when they get overwhelmed. So I'm not asking, does he hide from you or does he run from you? I'm asking, when he struggles at home, what does that look like? Okay. I'm just assuming. The other resource I want to make available is called the Pediatric Symptom Checklist. This is available for free. We will make sure you have the links and the resources. It's a brief questionnaire that identifies and assesses changes in emotional and behavioral problems. So there's a long version that's 35 questions, and there's a short version that's 17 questions. I love it because it's free. It's available in more than 24 languages, including a visual picture version. And it's appropriate for children ages 4 to 16. I haven't found a paid assessment that covers that wide of a range and has that many versions of accessing it. A couple other things about the pediatric symptom checklist is I actually first heard about it in a pediatrician's office. So it's not a diagnostic tool. It just is a simple behavior questionnaire that teachers can fill out, parents can fill out, anyone who spends any amount of time with the child. And then it takes the answers that the person fills out and categorizes if those behaviors are more significant than other children that age. And it puts them into subscales of attention concerns, internalizing, which is anxiety, depression concerns, and then externalizing, which is more like conduct or behavioral concerns. And so that can be really helpful if you have staff and you're trying to assess how a kid functions before lunch versus after lunch, or homeroom versus specials, at home versus at school. This is a super quick and easy way to have different caregivers and different adults fill it out and get an accurate picture of what are we struggling with this kiddo? Is it what kind of area? And again, it's not diagnostic, and so it's available to anyone to use. The other two screeners that you might see in the mental health realm come from a counselor or from a pediatrician's office is the Vanderbilt. That's the most common scale for assessing and screening for ADHD. And then the SCARED is an assessment used for pediatric anxiety disorders. So I'm gonna keep us going into this last slide really quick. A couple other options is to make sure that biological needs like hunger, thirst, and pain are being met throughout the day. All of these diagnoses have decreased body cues. So kids with these diagnoses are less likely to notice if they are hungry or thirsty or hurting. Using routines and visual schedules, offering independence or control, and sensory experiences. So flexible seating, headphones, light covers, lamps. Asking the team about pharmaceutical treatments and possible side effects. Stimulant medication is the most common medication route for ADHD, and that can have a real negative impact on kiddos' appetites. And so that may be leading to some adverse side effects. There's a wide range of medications used to treat PTSD and anxiety disorders. Some of them are anti-anxiety, but some of them are actually off-label for blood pressure, for example. And so just being able to understand if the child is on a medication and what might be some possible side effects that we're seeing in the school setting. The final action step is to be screening for increased risk of suicidal thoughts because of the distress that comes with any of these disorders. As I mentioned earlier, students are at increased risk. And so I've included some resources there for how to screen for that risk. I am aware of time and just gave you guys a lot of information. And so what I'm going to suggest that we do at this point, we do have a couple more slides on communicating with parents and tips for the classroom. I'm going to encourage you to read over those and have them available as a resource. But I'm going to turn it over to Kate to facilitate the Q&A with Heidi, just to kind of break down. And if you guys have questions about those slides, you absolutely can jump into them. It's not a pop quiz for Heidi. She knows they're there. She wrote them. But I need to just be a good steward of my time and also of those questions that are coming. So please, please, please just put out any questions that you have, and we will make sure to do our best to support you with some responses.
Awesome. Crystal, thank you so much. I was saying at the beginning of this, I've been really excited for this presentation and, know it inside out as well. And I just think that the resources are really valuable, and to provide some real world applications and examples of ways to talk and ask and inquire and, observe a student, I think is super valuable. So thank you so much. I think at this point, Heidi, I'll leave it up to you. Do you want to go straight into kind of the discussion opportunity and Q&A opportunity? And then again, there's just the couple of slides left after this. Everybody, you'll all get a copy of this as soon as this is over, so you guys can review as well. Or Heidi, do you want to go over them? I'll leave that up to you.
I'm fine with just so everyone can look at them. Okay, I'll literally just read through the slides. I know you all can, but we'll just have that information, maybe prompts quickly for any other questions or thoughts there.
I'll go back to this parent one then.
Okay, so looking at this one, this is similar to what Crystal was sharing before. Really, we're trying to engage the child or the parent as the expert on their child or the caregiver. Getting curious with them. What's worked when you've seen challenging behaviors before? What's been successful in the past, asking for their feedback, bidding them to share with you, to be an expert that can offer great insights to you in addressing behaviors or challenges in the school. And then suggesting that team approach. So focusing on common language and responses at home and school. So everyone's consistent, that we're giving this kiddo the same messages, that we're asking in the same kind of ways. And this can include focusing on our tone. How are we presenting this curiosity when we're talking to kids? How are we talking to them? What level are we getting on? Are we standing over them, or can we get down and can we look a little bit closer in their eyes and not be hovering above and just engaging that way? And then tips for the classroom, incorporating social and emotional learning content for the entire classroom. This is great for any kiddo out there, just to have all of the students getting some of the same language, the same messages on whether it's coping skills or talking about mental health issues, or what they might, normalizing what others' experiences might be as well, and having acceptance for all of that. Providing a calm down or regulating space that includes sensory tools or sensory options, either within the classroom or another place that they can go to. Focusing on some bottom-up approaches, starting with meeting basic needs, connection, and regulation before engaging the problem-solving logical part of the brain. When kids are dysregulated, they're typically in their limbic system. They're not in the talking, problem-solving part of their brain. And so if we can first regulate that limbic system and then invite the problem-solving at a later time, it'll be much more effective. We're more likely to see, if we shoot right directly for the problem-solving, we're more likely to see increased dysregulation.
Awesome. Well, thank you, Heidi. I think it was valuable to go through those two super quickly. These are all links. I know you can click on them right now in presentation format. So everything that these two just mentioned in terms of helpful resources and whatnot will be included in the follow-up here. You guys will all have access to this information. But at this point, I'm going to pull the screen down, and we've got about 20 minutes here to do a great Q&A session. This is a fantastic opportunity, of course, to ask questions, but then also, if you're experiencing a specific challenge within your role, within your school, with a specific student, it's a great opportunity to all sort of collectively come together. Again, just as a reminder, if it is about a specific student, we just, please omit any special identifying factors, name, ages, where you're located, et cetera, to protect, the safety of that child.